Welcome to the Birth Lounge podcast, an empowering space for expecting and new parents to hear candid conversations with experts, support your mental health, and learn the tips and tricks that thousands of parents have used to craft their ideal birth. We will answer all of your questions, the scary ones and the weird ones, to help calm your fears and feel confident going into your birth. I'm going to help you redefine what birth and motherhood looks like and how to embrace your journey. I've intentionally crafted a list of experts to help you navigate pregnancy, explore your birth options, and plan for postpartum so that it can be a time of soaking in your tiny human. We're going to go there on all the hard topics so that you can dive deep into finding your confidence and freeing yourself from fears around birth. With over 10 years of experience in family education and a master's degree in human development and family studies, I created this podcast as a way to share the resources parents need to make educated and informed decisions about their care in pregnancy and childbirth. This is a birth community driven by evidence-based information and research in hopes to help you explore your options, understand your rights, and know what choices you have along the way when it comes to birth and beyond. I'm your host, HeHe. Now let's get to the good stuff. Let me ask you something. Have you ever had anxiety about the conversations that are coming up with your provider in your prenatals? Or do you ever leave your appointments and think about all the things that you wish you had said while you're driving home, like kind of after the fact? Maybe you know what you want in labor, but you don't really know how to actually say it to your provider to communicate your goals or your wishes. Or maybe you keep running into the situation where people are saying, well, it's hospital policy, and you don't know how to kind of get out of that situation, but you know you don't have to follow that. There are no have-tos in birth, right? You are free to do whatever you want. I want to make sure that you not only have the data and the science to back up the choices that you're making so that you are making decisions that feel aligned with you, but I also want you to have the words to communicate that with your provider. And so I've put together a PDF guide that has a ton of birth scripts in there, and I'm going to take you through different conversations so that you can see how you can navigate these with your provider depending on your goals and your preferences during your labor. So you can download that at thebirthlounge.com/scripts -for-advocacy. You're going to find the most common conversations that people bring to me to get information and data on, and phrases to help them stay in control of that conversation. So things like big baby, being induced, birthing positions, Pitocin use, prenatal decisions, and so many other conversations that you need to know when you are going into your prenatal appointments with your provider so that you can continue to have this collaborative decision-making conversation throughout your pregnancy so that when you're in labor, everybody's already on the same page. People know what to expect. We have a plan, and this is what we're going to do. So download that at thebirthlounge.com/scripts-for-advocacy with hyphens in between, scripts for advocacy, and I'll see you in the episode. Bye. Hey y'all, and welcome back to another episode of the Birth Lounge podcast. All right, this is a part 2 from last week's episode with OB-GYN and fellow of ACOG, Dr. Darrell Martin. He told us in the last episode about being run out of town and clashing heads with the local hospital because he was trying to promote midwifery care as a way to improve maternal and neonatal outcomes. In today's episode, we're going to talk about the role of doulas that he's seen over the years and what his opinion of doula support is. I'm also going to dive into hospital dynamics and financial incentives and what really goes on behind the closed doors of hospitals. What does litigation look like, and the way that medical interventions are talked about, and are they pushed? Then we're going to end with the evolution of things like breech birth and electronic fetal monitoring, plus what the future of birth could look like, including birth centers and being an informed consumer. There's not too much of an intro needed here, so Dr. Darrell, welcome back to the show.
Thank you. This has been fun.
Absolutely. Okay, when we left off last time, we had touched on partner support and what you can do to plan for your birth pre pregnancy before you even get pregnant. Yeah.
Okay,
Yeah.
so I'm ready for some more questions then.
Okay, my next question is, what's your opinion on doulas?
Oh, I think are all doulas created equal? I probably not. So I think in general, the word is a word that I appreciate, and I think as a support, if you define them as a support person who's an advocate for the couple, who's there in their best interest, I think that is the best solution for labor support. Not the nurse who comes in and out of the room and they have 3 or 4 people that they're taking care of. Probably not the husband who is so emotionally caught up in things that he sometimes can't see the forest for the trees. I've had him argue with their wife about, you don't need to do this or you don't need to do that. And it causes a fight. I've seen fights. And he just needs to be there just to love on her and just support, but not worry about the technical or what's his experience. And unless he's been married before, and even if he's been married a couple of times, he's only been at a couple births. So I think a doula is the best solution. I think midwives to do the birth, yes, but they're not totally as objective as the doula would be. You have no skin in the game other than you want a safe birth. And you want to see the best outcome, a safe outcome, but you want to see her, you know better than that, even that midwife probably, about what her desires are. And you've spent time with her analyzing and explaining, and she trusts you. And trust is huge. Trust is huge for a birth because things can go south really quickly. And so there, if you, and I'm just pointing at you and say you are the doula and you represent all doulas, that if something's happening that's bad, they're going to trust what you say. They're going to trust you. No, I think the doctor is right here. That makes sense. Time is up. That tracing doesn't look so hot. You didn't officially take a class in fetal heart rate variability, blah, 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 failure. You have enough study that you understand those concepts better than she would, better than her husband would. And you have no vested interest in forcing her into doing a direction that may not be the best direction. You're always going to submit to the authority of the physician when they come in, but you keep yourself calm, cool, and collected. And I've worked with women that, I wouldn't dare argue with them because they can say it without raising their voice, without an attitude, and they're speaking truth. And when you get that sense of their spirit that they're speaking truth, you're going to calm the room. You're going to calm the couple. You're probably going to calm the attack that could come from a labor and delivery nurse, from a midwife, from a family member who comes in, that pops in and wants to sit in the corner and just observe. You've had those, right? They have really no business to be in the room. They're just there to watch. And you're okay. But then when they start expressing their opinion, it becomes, you got to know how to deal with people.
Yeah, I think that's one thing that catches most couples off guard is that there is a power dynamic in that birth room and someone is going to be in charge of it. It can either be you or it can be someone else in the room making the decisions, but either way, that power dynamic absolutely exists and there's different personalities and I think a lot of people are very unprepared to navigate that space. They either go in expecting everyone's going to fight them or everyone's going to be so nice and so kind and so open and yep, let's do that. And very rarely do you fall on the outside of those spectrums. It's usually you've got a couple of different personalities at play and they fall differently along the spectrum of that.
Yeah, and if the particular doula knows the hospital, they've been there for more than just this birth, so they know the games that could be played there, and they know how to navigate that, and they know how to prepare the couple ahead of time if this is the only game in town, so that you're going to have to deal with certain things that could happen because of that particular hospital.
Yeah. One of my favorite things about being a doula is establishing that relationship with those hospitals. So if you are a doula listening, let me tell you something that I did not know I was working towards, but now that it has happened, it makes me very proud. My clients will often tell me that the way that their hospital staff acts when once I have arrived versus before I had arrived is very different and it's much more consensual, which lets me know I have created a relationship where they know, oh, I should really do consensual care, or HeHe is just going to correct it. And I always do it in a very kind way. It typically looks like me asking that mom, is that okay with you? So if a provider's not giving consensual care, I'll just quickly insert, oh, Meg, is that okay with you? And then that gives the room some pause to say, oh, actually, I'm not. Or, yeah, that's totally fine.
Sure.
Perfect. That was the consent that we're looking for. So, for doulas listening, you can absolutely cultivate that relationship where these staff, I also should tell you this, and I've mentioned it before, but when my team gets to hospitals, the staff recognize us because we're there so often and we have been there for so many years. We have a really positive relationship, but it is one of respect. They know that if consent is not gotten and we're present, we'll definitely make sure that happens. And if you're working towards building those relationships as a doula, keep going. The more that you're at those hospitals, the more interactions that you have that are positive, the more that you can show hospital staff that we can work together. You will
Yeah.
eventually get there.
And if they're wise, if they're objective, if the staff is objective, you're providing a lot of the work that they don't have to do. You really, they can take a chill pill a lot if they know you're in the room and that you've got it covered. Their work is made easier. They should see it as their work is made easier because you're
I love that. I've always said that as well, but I know that's not always the perception, and that's okay. Okay,
there. Yeah.
my next question is, do doctors get paid more for C-sections over vaginal deliveries?
Yes.
Wow.
Now I'm out of the business for a couple of years, but there is a higher reimbursement if a section occurs, if a vaginal birth occurs, just like there's probably a higher reimbursement for high risk categories, more visits, blah, blah, blah. Now it's not huge. It's not, it was maybe $500 more. It wasn't like two or 3,000. Now it is quite frankly more for the hospital, much more money is going to the hospital. If you pull the numbers from your hospital, what is the cost for a 24-hour stay in a birthing room with a vaginal delivery, without this, without that, versus with it, and then a section on top of that? I bet those costs can go to $30,000 or $40,000 easy.
Yeah. Do you think that's enough financial incentive to influence providers in recommending more C-sections?
I would hope not. I would say probably not. I think what the incentive is to get them home sooner. It's time, it's not money. If I can convince, and I'm not saying this 100%, because we don't want to hand out my information to too many physicians who are going to come after me for some of these statements. Because it's, and I had a friend who said one time, if the shoe fits, wear it. So if that's what you and wear it, don't be aggravated. Just keep your mouth shut because that's you. If
Yeah.
it if it's not you, don't worry about it. Don't worry about what I'm saying. If it doesn't affect you, then you're okay.
Keep scrolling.
No, but I don't think there's a financial incentive. I sure hope not. But when it comes to, I think there's an issue of litigation. I think that physicians, maybe with that fear in certain states, maybe that fear is greater than in other states, that to cut bait quicker, to rarely would there be a lawsuit over a C-section, an unindicated section. How many suits? There would be a handful, probably, of suits where someone comes back after because you did a section, the mama has a pulmonary embolus and she dies, and says, but you shouldn't have done the section. That doesn't happen. It's more the litigation happens because of non-intervention than the intervention of an induction or the intervention of a C-section, right? So I think they do it because of litigation fear at times, not money. I think they do it for time, for convenience.
Yeah. I think that we're starting to see the first kind of wave of litigation for being too much of an interventionist start to hit the field. Hermine Hayes Klein is a lawyer that deals with human rights actually and does litigation against medical systems that have coercive medical practices that have caused significant harms to women and their families. I hope to see that kind of balance things out. I never want things to go to litigation. I just would like for collaborative care to happen so that nobody
Yeah,
has to go to litigation. But since bad things are happening, I am happy to see that they are being talked about and that at least repercussions are being talked about and considered too.
absolutely. And there's good and bad actors in medicine, and there's good and bad
Totally.
actors in legal issues, right? And I was always adverse to the advertising issue.
Hmm.
And it's become more prevalent, but it's always been prevalent for, in general, I'd say, for attorneys, for marketing themselves for accidents or for malpractice. And typically, the kind of litigation that occurs is for misdiagnosis, like missed breast cancer is a big one. The ones obstetrically related would be a bad baby outcome. So, shoulder dystocia would be probably the biggest one. Those are probably two of the biggest: misdiagnosis of breast cancer, colon cancer, because those are bad outcomes typically when they're missed. Bad outcomes for the mother. Or in terms of obstetric, it's a bad baby. Shoulder dystocia, Bell's palsy, something that's not recoverable from neurological issues. Hopefully that's less and less. I would expect it's less and less just because physicians are so fearful of that they're intervening sooner.
Hmm. I
And,
think
and
you
so,
might be surprised. I don't know. In my experience, most recently, it is that providers are providing so much support at the time that the baby is actually crowning and being born that it causes sometimes some harmful things. Like it almost causes shoulder dystocia. They're not waiting for restitution and they are not letting women up off their backs because they want to be able to help deliver that baby. Where if they were on hands and knees, you might not have to intervene. If they were standing up, you might not have to intervene. What do you think about that?
oh, I think that all fours would be a great way to avoid shoulder dystocia.
Yeah.
But gosh, and she was at my book signing, and she's now in her late 80s. She started the farm in
Ina
Tennessee.
Mae Gaskin?
Yeah, Ina May is a friend, and I've had dinner with her and lunch, and I've encouraged her to do another book. And on she's done over 2,000 births, and she has a philosophy of how she treats shoulder dystocia, which to me is the way to go. I met her. She came and spoke to our residency. And that was another big impactful moment for me. Most of my resident friends were sitting there making fun of her and the fact delivering out on the farm in the middle of a field and talking about the sheep and the cattle there. And so there's a little funny line in my book about that. But she's a great person and has a lot of knowledge, empirical and just knowledge. She's basically a doula. She wasn't trained as a midwife, but gosh, her experience is incredible. And yes, so I think they're right. You're right. They go into panic mode with that child, and there's certain predictive. You know, the less interpartum um, intervention, the better, because then you're allowing to see how nature is really working.
Mm-hmm.
Anytime you add something, even if that's medication, you're adding an epidural, you're intervening and you're not quite sure where is the arrest of labor coming from. You're not allowing them to move around, get up and walk. You're blocking the natural processes. And how much is that the problem versus the outcome that you all want to avoid, and that's an unhealthy baby? And you maybe unfortunately contributed to it by your intervention. But yeah, shoulder dystocia is a scary thing, Midwives are all, obviously, because physicians, for the most part, in most, I hope, hospitals don't have to be there when a midwife's doing a birth. And so they need to be trained in that. And so the first way to train is changing positions.
Yeah, I was going to mention that not all interventions are medical or medication. It can look like a position change. That is an intervention. So if that's being suggested to you, really think about what your like intuition is telling you. You want to always be following your intuition. So take the things that are being said to you as like suggestions or options. It could also look like a cervical exam. That's not medication, but that is an intervention. The
Sure.
words, the information that we get could even cause a mental block, so that might be an intervention point. So just think about all of that. I could not agree more about just letting birth flow, and as long as things are working, we should just be watching the process happen. Okay, my next question is, what is up with baby's heart rate dipping right at the time of birth? I feel like we are seeing an increased number in the hospital. And keep in mind, a lot of these people do report being on their backs, and they typically are having someone monitor that baby with one of the paddles all the way down close to the pubic bone. And kind of right as their baby is being born, you might hear their doctor say something like, your baby's heart rate is not looking so awesome, so we really need to get your baby out. There is one camp that says a heart rate dip in your baby right as they are being born is very normal. And then there is obviously the medical camp that says yes, and if it's too far below, it's obviously dangerous and very concerning. How, as a patient, are we supposed to discern between these two to determine whether this is a normal heart rate dip, and I guess confirm if that is normal, versus a true emergency where there is massive concern? Or is there a way for us to know this as patients?
There's multiple questions in what you just said. So I got to figure out, first of
Yeah.
all, I don't think that the patient and her husband are capable of discerning the difference. They're going to have to trust the provider to discern the difference.
Okay.
That's number one. I don't think they're going to have enough ability. Some physicians can't figure that out. So how is the patient going to figure that out? I think if nothing has happened to that point, you have great variability for what you can discern with external monitors, which you can to a large degree. If nothing has occurred until that point, there's not some progression of deeper and deeper decels with no recovery or a problematic recovery. So you're a little more worried in those situations than you were. Hey, everything's great. It's been 120. It's been variable, da da da. But then suddenly, right at the end, it drops. That's a healthy baby. That baby's going to bounce back and recover. It may have a lower 1 minute APGAR, but the 5 minutes is going to be fine. What happened before that happened is important. Also, who is this mother? Does she have any medical things? Was she a diabetic? Was she a hypertensive? Is her BMI over 35? Or is there some other things going on? Most things don't just occur in a vacuum. There's other factors that you're thinking about in that process. And without getting too super spiritual about it, I would trust the spirit for me to really discern what was happening. And it's kept me out of a lot of trouble that I wouldn't dare tell the nurses or the patient that for fear they think I was a wackadoo. But you get, if you're there more, if you're bopping in and out, if you're the physician, you're bopping in every hour or 2 hours, blah, 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 you're not going to pick up on some of that stuff. So if you're there at the last minute, you may panic. And if also you're a less self-assured provider, you're going to panic a little more. But I think in general, the signs before it happens right at the end. The cord can get a little tighter. This cord compression typically that's going to cause that decel down into the 60s that everybody goes, where's the anesthesiologist? Bring me the forceps. Let me pull. We lost a baby in Atlanta that made the news Did you see that?
Yeah, the decapitation, that was
Yeah.
absolutely tragic.
Yes, and that was panic. That whatever happened, I don't know what happened, but how can you do that? And it just sends chills. And that was the hospital we used to work at. I know the hospital. I know who the physician was only indirectly. Never worked with her, and never really saw anything, but I knew who it was, and that has to be. She stopped practicing, but anyhow, yeah, I guess if that answers your question, I don't think the patient can. The patient is going to have, the client's going to have the trust. That's a big trust one there. And then the provider has to have enough experience to know how much longer can I wait. Just chill. Let's move around a little bit. Let's see if we get a difference. She's stuck with an epidural and she can't move. That becomes a whole
That
nother.
changes things,
Oh
right?
yeah, you'd rather have not have that on board so you can change positions and you can get her up and da 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 da. But
I think a lot of physicians today would rather their patients have epidurals. I find that there is a large number that almost suggest it at certain points in labor.
I would agree. Yes, I think it facilitates, it controls things, doesn't it?
Mm.
Because you can turn it up, you can turn it down, and you can control when the birth to a degree. If you can't feel anything, it's pretty hard to push. Then you're not going to get up if your legs can't move. So no, I would never say you can't have an epidural. That would be silly. That
Yeah.
Yeah, because then they would say, "Why don't you lay down here and have this birth?" Okay, I'd probably have an epidural when I conceive. I don't know. Men are wusses, so we don't handle pain very well in any kind. We want a lot of care. We get sick and we're down on the bed. I can remember when I had COVID and I had it early on, and there was no testing. There was no testing. It was so early that there was no. But I felt weak and tired, and did some blood work, and my white count was like 2000, and it said be avoiding anybody with infection because your immune system is shot. I know why my immune system is shot. So I went home and laid on the couch for a while. And my wife gave me no empathy at all. She said, "You're just being a lazy butt." Because I didn't have a test to prove. Because what I would do would be every day I would go downstairs to the Peloton bike and I would get on it and I would check my heart rate to see what my heart rate would do because that was my test to see I could breathe okay. I wasn't in any respiratory difficulty. But I was extremely fatigued, and I would check my heart rate, see how high it would get and how fast it would get if I wouldn't be on it for 5 minutes just to see. That would be my test. I didn't have a pulse ox at that point to check to see, and I didn't have to go to the hospital and didn't take the drugs. But anyhow, that's a whole nother story. Yeah.
So a lot of parents do not get very good, clear descriptions of the fetal scalp electrode. So how do you describe the fetal scalp electrode to parents?
I'm smiling because in 1973, our head of maternal child health, he trained with Ed Hahn in Yale. And he, because his family was quite wealthy, brought the first fetal monitors to Vanderbilt.
Wow.
So I was trained with fetal monitors. I was up there with a cone doing scalp sampling, way too many, way too many to see what the pH was. And it was a reassuring thing, but boy, that's tough on the doctor to do it, let alone the patient who you've got this cone in there and you got it up against the scalp. You got to clean off. Have you ever seen one done?
Yeah, only one. And it wasn't super bad to see it be placed, but for me, it's when the discussions happen around it that they say, oh, it's just a little sticker or a little clip. And you're like, it's absolutely not. This is a metal wire that is screwed into your baby's head. And that's actually what ACOG does describe it as. It says it is something that's going to be screwed into your baby's head. And so it's just, I don't know. I have a big problem with how it's presented to patients, and I
Yes.
think a lot more people would have questions if they knew truly what it was.
Well, now see, I jumped over. So you're defining. I'm talking about old school when we did scalp sampling. We nicked the scalp and drew blood in a pipette to do a scalp sample pH. You're talking about putting an internal electrode on to perhaps well, it probably does more accurately discern fetal heart rate variability. Now,
Right.
I jumped ahead to something that hasn't been done since probably the 70s, and when all the investigation was being done, because a metabolic acidosis, the pH is 7.1 on that with that heart rate trace, because that was new. They were just, Ed Hahn was the originator of fetal heart rate testing with fetal monitors. And
And
then,
you were trying to see if by introducing these electronic fetal monitors, could we prevent possible cerebral palsy and oxygen deprivation and complications of that by introducing these electronic fetal monitors. Is that what you're talking about?
yes, and the belief when it was all invented was that it would lower the section rates and improve fetal outcomes, right? Not so much, because it forced people to be on their backs, and misinterpretation. I can't tell you the number of times I would walk into a room and there would be a monitor. And again, we're talking about the 70s and early 80s. And then I'd walk in to see the patient. That was before I had the midwife, before we hired any, because I was just flying solo. I was an employee, right? And I'd walk in, and that patient would be on their side with oxygen going, because the nurse thought it was a bad monitor strip. Now, I mean, I was trained with the guys that invented, the how to evaluate monitor. I was very comfortable with what a monitor strip could and couldn't do. But you have a family in there, and that nurse puts oxygen on and puts them on the side. That freaks everybody out, and it puts me on the defensive. And then you go in there and they say, the nurse thinks I'm going to end up with a C-section. I said, I'm rolling my eyes. I'm thinking, okay, she set me up. She's really set me up, because when she's playing that song to the family, when she's wrong 98% of the time, the family forgets that. She guesses wrong. She's making a guess. Oh, this is a bad outcome. So she's intervening when it's not necessary. And it's setting me up to have to try to disprove the nurse and to try to calm the family down. And when the happy birth happens, they forget all about that nurse who said, oh, you're going to need a section. Now, I've had that happen plenty of times years ago. You're going to need a section. Having the doula there helps to run that interference.
Yeah.
But I've had that happen plenty. Now, that's a long time ago for me in terms of dealing with that.
Yeah.
And that's why I've evolved in hindsight. And I think we did things well, and we avoided interventions unless the patient was so adamant, like, I want an epidural. We're not going to tell someone you can't have something.
Yeah.
We're not going to say you have to scream and yell and shout to do it. I'd like to educate you, and that was the purpose, obviously, of having the midwives on board. But I just would do it different now. I would do it different. I would never let the practice, if I was in a practice, get too big, and I would only have births occur with wives, and I would encourage doulas. I wouldn't hire the doula, because I believe the doula needs to be independent. There need to be someone that's independent, because anytime if I was paying them, then no, I think that they should use them, but I don't think that they need to be independent from the hospital. They need to be independent from the physician, because their only interest is they're getting paid to be for the patient, period.
Yep.
If
And
you have no
they're supposed to be a neutral third party. They're supposed to present you with information that helps you make your decision. And it's a transparent conversation of the pros and the cons and the risk and the benefits and the alternatives that may be available, and questions to ask your provider. But your doula, I believe at least, should not be swaying or influencing your decision. But if they see coercive care, you're not neutral about that. So don't make a mistake about that. If
yes,
you see something, you should say
see
something.
something,
But
say something, right?
yeah, but you shouldn't be influencing your clients' decisions or their choices. And withholding information that you know might do that is just as bad as directly trying to influence them. You are supposed to just present things neutrally.
Yeah, and they have to have enough trust. And I certainly hope, I guess there's always exception to the rule. The only thing I can think of where a doula could be vested in another way would be if they're pushing to intervene to get a delivery done so they can go home. Time is their only issue that someone could complain, just like they could about the physician or the midwife. But there again becomes the trust level and the experience that you have with that particular person. And again, the more that they've learned, and that's what I'm sure. I don't know how many visits a couple has with a doula ahead of
Yeah.
time.
Yeah.
And so the more they have, the more connection, the more trust.
Yeah.
And so that's what you have to have, that trust. There's just no way, because bad things are going to happen, and they need someone there that they trust.
Yeah, for sure.
And you
Um,
don't do this for the money; you do it for the love.
It's actually so true. It's not great money being a doula, but you do it because I do it at least because I know that women deserve more. I know that they are capable of having good, positive births that
Yeah,
empower them and don't break them. And I want to show them how to do that. So, yeah. I get hired by a lot of clients who have previous birth trauma, and they come to me to have a positive one and to almost have a redemptive birth. And a couple of other incentives when you were talking about doulas speeding up the process comes to mind is when doulas are really they're almost like a wedge in the birth room, and they're really like trying to wedge between the client and the doctor, and they're not creating this cohesive team. And we talked previously about the medical providers being cold and distant to doulas, but doulas can absolutely be cold and reserved and almost resistant to medical care so much that it can interfere. I got a call from a nurse friend that was looking for some advice on maybe just what options did this unit have, and they had a doula that had convinced a mother that truly needed some medical intervention to not get it, and she had convinced her that the hospital staff was just trying to, in fact, put on the cascade of interventions like we all know absolutely happens. But this was a case where the medical intervention actually was necessary, and it ended in a fetal demise. And so you can absolutely have the opposite end of that
sure.
spectrum. You might have a doula too. I think now I'm rambling, but I'm just thinking that if you're interviewing doulas, understanding how they interact with your hospital staff is really important. If you're hiring a doula and you're hoping that she's going to be doing hip squeezes and suggesting positions and helping you get in and out of the tub and working collaboratively with your medical team, but you hire a doula that actually just believes her role is to hold space, and she's quiet, she sits in the corner, she's not going to do pain relief, she's just there to hold space. People bring different energies to the birth
Sure.
space, and they have different approaches. So if you're hiring a doula and you're listening, I would add that question to the things that you're going to ask. Hopefully you're interviewing different doulas so that you can get a feel of who's in your area, what they bring to the table, and how each person might be able to best support you, and how they'll be able to play a role in your birth space, because that'll matter. It matters a
Yeah.
lot.
Yeah, it's that takes a village, right? And so that's just part of the village for some people. And thank goodness that option is available in a lot of locations. And midwives can accomplish that if that's their only person in labor for that day. Let's say
Yeah.
they can be, then they become like a doula. I would say I was the doula for my daughter-in-law, and I was had no other purpose. That was my only purpose, to be in that room, was to support her and get her. I mean, I knew it was going to be safe. There was no. I knew. I also knew that one of the best physicians I've worked with during the birth, so I knew we were in good shape, whether I was there or not. But it was such an amazing experience to do that. I guess that's my one of my best birth experience, other than in good hands.
Okay, I want to know about, tell us about the breech births that you used to do and what it was like seeing that almost be completely eradicated from the US healthcare system.
Oh, mate, the majority of them I did when I was in residency. There's no fear when you're in residency, right? You don't even think about consequences. Now, you had to follow protocol, or you could be in a world of hurt with your professor. So some of the most dangerous ones where you get too cocky about are 32 to 34, 35-week breaches, because relative to the size of the body, the head's a little bigger, and that head can get trapped in the cervix more easily than one that's a term. So you get a little too cocky and say, this one's not going to be too big. Some of the toughest ones, and I've had to apply pipers inside the cervix to get the baby out.
Mm. Now,
Um,
you talking about hands-off breech birth, or you always doing extraction?
no, I don't always do an extraction. You just see what's happening. And ideally, she doesn't have an epidural. And ideally, she's able to adequately push, because she has a vested interest at that point. She's all on board. And usually, a lot of them that were with the midwife, I would let them do those births if I was in the room. So I'm just saying that it's my hands. If it's their hands, it's my hands as far as I'm concerned. I'm watching everything they're doing. And why not? I've had them do twins with me. And if I'm there, I'm not going to be outside in the hall, but I'm going to be there with them. And that would be a joy for them to get to experience that, because I would say at that point, their hands are my hands. And you learn, you knew enough of them, the maneuvers, you just leave it alone, and it's going to usually work out. But you might do a little rotation here or there. She poops out, and you might now in residency, it was cool to put pipers on. I'll be honest, that was pretty cool. And in some of those, we grew up in a generation where if you were the forceps master in residency, that was a
God.
retirement present I got, was a plated set of forceps from Upright.
Oh, wow. Okay.
Never to be used. I didn't like vacuums. I really didn't. I didn't see a whole lot of help for those things. And that was a trend there. Everybody wanted to put a vacuum on, because they didn't, quite frankly, they wanted to expedite the delivery, but they didn't know how to use forceps. There are good people who do forceps, and there are bad people who do forceps. Those mid rotations, I've seen some of those in a hospital by older physicians as a resident. That just scare the bejesus out of you. And then the applications that are pelvic applications, where it's not, you're just, yeah, they were interesting, as to say the least. But the breaches were cool. The twins. I delivered a lot of twins with. Now you may get by, if it's vertex, somebody may do a twin birth. But no, residencies are getting less and less, in my opinion, experience. And particularly, hopefully they're at a big enough institution, they're getting them to do a lot of births. But the other part, not so much, because now there's fellowships and everything. So you're down the ladder of getting to do some surgical procedures, because there's not as many, and you have all these fellows that are in front of you doing those things. With birth, it's a big enough place, you're going to see enough to know what the problems are. It's just, but you got to be in the room. If you're a provider, just walking in at the last minute, bebop, is not the way to learn to do obstetrics. So that's why I think, because you get so wrapped up as a resident into all these things you're supposed to know, not just birth, that's why it's better the midwives do.
That's what I was just about to say. That's why it's better to just have midwives do the birth,
Yep,
and they can be the birth experts. And then if you need something more, like a surgeon or an MFM, then you can refer out to someone who
absolutely.
specializes in that part of the pregnancy process. Okay, recently in the news, recently in the last year or so, Florida has announced that it's going to attempt to do C-sections outside of the hospital. What's your opinion on this?
Depends what outside the hospital means. And that connotes different things to different people. So they're thinking someone's in a tent somewhere doing a section like Civil War days or something. I don't know. But seriously, if you have a birth center, chances are they don't have an operating room suite. However, someone who has a birth center, that could be affiliated with a hospital, that could be independently owned. If it's independently owned, perhaps My preference would be that's co-owned with the midwives and a physician consultant, but there's a surgery center there. Surgery center has an operating room. People have knee replacements in a hospital OR. They have knee replacements in a surgery center. Now, typically they pay less in the surgery center. Hospitals typically charge more. So the advantage for the birth center, if someone needs to, typically that would be what? Failure to progress. There are certain qualifications or requirements that people risk out of delivering in a birth center. So they're there at the birth center. So everything's been totally normal, depending on what protocols they're following. Typically, it's all normal. So chances are what's happening is they've had less interventions, right? While they're at the birth center in labor. They haven't had some of the interventions. They certainly aren't going to have an epidural. And maybe they have some pain medicines, probably. But they have a lot of hands-on care. And they're up and ambulating. So then what would be the most likely reason for a section at a birth center? Probably failure to progress. And probably there's not going to be a big drop in the heart rate. You have a surgery center there, that's no different than the OR at the hospital that you've gone to. And possibly, they would have a consultant on staff that's a pediatrician, maybe a pediatric group. So that's taking some call there when they need it. I know. Back, I'm in the old days. I've intubated babies. I've done a lot of interventions for babies because there were no pediatricians there, and the anesthesiologist hadn't done too many little babies. So I've done some intubations on babies. Probably the obstetrician is not well trained enough today to do that. Just our experience was just a whole lot different. But I don't see why it's going to be less expensive for the person if it's going to be safe, meaning from a sterile standpoint, if it's a surgery center room, it's less traumatic because if they fail to progress, how long is it going to take you to get from that birth center into an ambulance, to the hospital, to that labor and delivery suite where there's an OR to get that section done, right? That's got to add at least, I'd say more than 30 minutes, probably an hour to the delivery. Unnecessary. If you had just had a birth center, you probably can't afford to have a surgery room there. May not be able to be justified. But if you're part of a group, that's where collaborative practice comes in, I think. You have enough people in this practice that they have their own surgery center too. And I think that's what's going to happen if it's going to happen in Florida, where they're advocating for it.
Yeah.
There would be no incentive for a hospital to have a birth center and add a surgery suite if it's in the hospital, right? They'll just take them down the hall. It's not cost effective for them to do it. But you got a birth center and you put that, but you're also using that room or couple of rooms for elective surgeries, right? Tubules or some outpatient, a lot of outpatient surgery now. You have less chance probably of infection if you get out of the hospital than stay in the hospital.
Yeah, I'm sure that the hospitals don't like the surgery centers. It's got to be a
No,
loss of revenue for them.
absolutely. No, they fight them all the time. Anytime someone applies for a surgery center, it's blocked or it's attempted to be blocked politically. And they always go after safety first, right? And then they go overutilization. These orthos are putting in a surgery center and they're going to do more procedures because they own the surgery center. There's the games that are played politically, or no matter what profession you're in, they're played. And power breeds control and money and all this stuff that just messes us up a lot of times.
Yeah. Jeez. I'm hoping with this podcast that we can start to help people just become a little bit more aware and help them have the resources to navigate these different systems that are set up so that they can be prepared and informed. And we've said it this whole time and the whole last episode that the more informed that you are, the more educated that you are, the more you'll be able to navigate not only the hospital system and the birth process, but all systems, that should be your goal, is to get informed, be an informed consumer, and know your options so that you can engage in these conversations with the systems, essentially.
Yeah, I think that maybe the thought occurred to me that if there's nothing more, a starting point before someone conceives is they have available to them a checklist, and a checklist of 20 or 50 items with the resource to how to gain. This AI stuff is crazy. You can put almost anything on an AI and you're going to get an answer that's maybe longer than what you really want. But seriously, a checklist, preconception checklist. Have you just talked about this thing? You thought about what hospital? You thought about what your birth is going to be like? Have you checked out on the medicines you're on before you conceive? We know that, and you know this, that a baby's organs don't start forming to day 17 of life. I would say be careful how, if you're smart, if you recognize the fact if you're late for your period, that if you haven't stopped your medicine, you have 3 days to think about it and get an answer before you continue to take a medicine that could be problematic.
Mm.
Ideally, you've assessed that before you conceive, but you still have 3 days after a missed period. The organs don't form from day 17 to day 49, and then they just get bigger. So you have that protection. God put that in there. You miss your period, you say, oh, I could be pregnant. Maybe it's a good idea to check and see. So I'm on a medicine that may cause me a lot of stress when I think about whether I took it. Most medicines that are taken before day 17 are usually all or not. If they've taken something that's really bad, it's going to cause a miscarriage, but not a baby to be formed with some deformities. So
Mm.
I think a checklist is a good starting point. Then they don't have to pay a whole lot for a checklist. Then they can decide how they want to get the answers to the checklist for their particular location, because it's going to vary by location. Some people
Yeah.
get a choice. They can go to 2 or 3 different hospitals. Other people have no choice.
Yeah.
And some people have doulas available and some don't. And some have midwives available and some don't. All places where you deliver aren't created equally. So
Yeah. That's why it's so important, I think, to be very intentional in the way that you craft your birth. Be just really intentional. Okay, my last question for you is one that I get all the time.
okay.
What do I do if my doctor is not on call when I go into labor?
You should have prepared for that one ahead of time. You should have known who was the alternative if he's not. Now he could have a heart attack, obviously, and he's not available because he's sick. That's a different scenario. Then you're caught with the fate of who's going to be there because he's chances are he's got someone to back it. But you should know long before that day occurs how many days he's on call and who's his backup. That would be an absolute, you should know that before you even pick that doctor. You should know who he covers with. If he says he covers every day, then that's wrong. He doesn't do that. He's lying like a dog because he can't possibly do that. That's
What about
impossible.
doctors that are in big hospital groups, though? Brigham and Women has tons of doctors. So it would be impossible for your provider to tell you who might be on call when you are there.
That's true. But the important answer to the question is that I don't know who's going to be on call then. They need
Just
to
the
know.
truth.
Yeah, yes. They need to know that at the beginning. And if that bothers them, that their person, and then you would say to him, how often are you on call? If he's on call once every 30 days, the odds are great that you're not going to have him for the birth unless he induces you.
Hmm.
So you want to know that before you pick them. You want to, that is a big checklist question.
Yeah.
Don't wait until you're 39 weeks and try to think about, oh, he's on vacation the next 2 weeks. What am I going to do? That happens.
Yeah.
He's not predicating his vacation on when you're going to be delivering.
Yeah. Yeah, that's true. Although they might try and induce you to deliver you before they go on vacation. We get
Yeah.
those all the time. People writing in saying, my
Yes.
doctor tried to induce me because they were going on vacation or whatever. So Be aware of that. Oh, Dr.
Okay.
Martin, this has been just such a wonderful conversation.
Yeah.
I feel like there is so much that we still could talk about. We could just talk for hours, but it's so refreshing to hear an obstetrician that really values the midwifery model of care, that really understands patient autonomy and truly respects the freedom of choice for patients to be that active participant in their healthcare and to really cultivate that collaborative care feel between patients and providers. I think that's the goal for so many of us. And right now, it's just not happening. And so I'm very grateful for you coming on the show, not once, but twice. So
Yeah.
thank you for sharing all your wisdom with us. And I know we told about it last time and we didn't talk about it in this episode too much, but tell us a little bit about your book and where someone can order that.
Sure. It is a book of basically of my life, but it really focuses on my time spent in obstetrical practice and particularly advocating for midwives and the journey that took me on to support them in advocacy for what they deserve to be able to do. It's available on Amazon. It's available on Barnes and Noble, Books a Million. It's available on our website. So any of those places it can be found.
Thank you so much. Is there anything else that you wanted to say or share that's on your heart before we hop off?
No, I think this has been great. I really enjoyed it because it brings back so many very positive memories. A lot of births start going through my brain as you ask the questions. And sometimes you don't see the forest for the trees. When you're in the middle of doing all those and you're on call every other night, even though you're not doing the births, but you're still responsible. You take a lot of time away from your family, but it's so great. The relationships are the key, and that's what life's about, is our relationships with people. And so I have those good memories. I'm sure you do, and you can think about some of your great births and the people that became more than just someone you were doing the delivery for.
Yeah, absolutely. I always say to clients, this may be the beginning of our relationship here, but by the end of it, we will be family. So don't you worry.
Yes.
We are going to get to know each other really well.
Yeah.
Thank you so much for being here. Truly,
Sure.
this has been such a joyful conversation. And again, it's just so refreshing to have these conversations with an OB that gets it, because I know that the healthcare system is really hard, but it can feel a lot of times that obstetricians are a little bit more resistant to these types of conversations and these ideas and these topics and being open minded. So, thank you for being that and being here. You guys, don't forget to order your copy of In Good Hands, and I'll see you in the next episode. Be sure to follow along on social media at Tranquility by HeHe and the.birth.lounge. Until next time, head to your app store and download the Birth Lounge app for evidence based childbirth education and data driven postpartum support delivered straight to your phone. Bye. Thank you so much for tuning in today. I truly do value this community and I love hanging out with you. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent. It's an honor to be your go-to gal when it comes to preparing for your baby. If you found today's episode helpful, share it with a friend. Share it with someone who could use evidence-based information to help them have an informed and confident birth. I'd love to hear what you have to say and read your sweet words. By leaving us a review, you are helping other expectant mamas and their families find the podcast so that we can reduce birth trauma and improve maternity care in the U.S. one birth at a time. If you're interested in joining the Birth Lounge, go to thebirthlounge.com. If you want to connect with me on socials, you can find me at Tranquility by HeHe on all platforms. Until next time, stay educated, stay supported, stay confident. Bye.